Let's discuss some of the various prenatal tests that can be done to assess the fetus throughout the pregnancy. Some of these tests can be done to screen for genetic issues. Others will be done as the pregnancy continues to assess how the fetus is growing, being oxygenated, and tolerating the intrauterine environment. A non-stress test, a contraction stress test are both done after 24 weeks because they involve fetal heart rate monitoring. Ultrasounds are obviously used throughout the entire pregnancy in different ways. A BPP is an ultrasound test that can be done on a fetus after 24 weeks to assess oxygenation and how well the fetus is doing. Another type of ultrasound that can be used is an amniotic fluid index, or AFI. That's an ultrasound that simply measures and quantifies the amount of fluid in there. An amniocentesis, an AFP, chorionic villi sampling are all tests that can be used to screen for genetic issues earlier in the pregnancy. Doppler flow studies is a highly specific and technical ultrasound exam that is looking for how well the baby is being oxygenated, specifically through the umbilical veins and arteries. There is an excellent table in your text on page 357 that gives you some very good information about assessing for genetic disorders. I would strongly suggest you review that, be familiar with the gestational ages and the reasons that these tests are being done. The alpha-fetoprotein is specifically performed usually between 15 and 18 weeks gestation. It is looking for a substance produced by the fetal liver. Levels of this substance can indicate, for example, increased levels could be neural tube defects. Decreased levels could indicate Down syndrome. One of the disadvantages of this test is that it is very dependent on having an accurate gestational age. If you are off by even a week or two, it is very easy to get a false positive on an AFP, which is why some practitioners use it for everyone. Most practitioners now are using it only in moms who have higher risk factors. High risk factors for genetic issues would be a family history. One of the more common risk factors is simply age. As the woman gets older, she has an increased risk of having genetic issues with the eggs. Greater than 35 is considered advanced for maternal age. At the age of 40, those increases, or the risks, sharply increase. An amniocentesis is a more invasive test in order to get genetic material to send off and test. An amniocentesis can also test for chromosomal abnormalities. Remember, there is a difference between genetic problems and chromosomal problems. An amniocentesis can be done between 15 and 20 weeks, or may be done for different reasons at the last trimester. If done earlier in the pregnancy, it is usually for genetic reasons. If you look at this picture, you can understand why you can't do this test too early. Between 15 and 18 weeks, your fetus and your uterus are large enough so that you have the capability of introducing a needle to collect a small sample of that amniotic fluid. If you did it earlier, that could be an issue. If you're doing this particular test later in the pregnancy, the most common reason for it being done in the third trimester is to assess the development of the fetal lungs, usually because we're trying to assess the risks and benefits of early delivery. If the Lacethian and sphingomyelin ratio, you can see why we call it the LS ratio, right? If the LS ratio is 2 to 1, it confirms that surfactant is being produced, and we can be pretty sure that that baby will have decreased respiratory issues with an early birth. This test isn't used as often as it once was, but is a really interesting thing to watch if you get a chance to see it done in clinical. Moms tolerate it pretty well. A chorionic villi sampling, also called CVS, is taking a sample of tissue from the fetal side of the placenta. Again, this can detect genetic disorders. The advantage to this test is that it can be done earlier than amniocentesis, between 8 and 12 weeks, and the results can come back within a week. This can be helpful when the parents are trying to decide on a plan of care, but never assume that just because patients are having early tests you can assume that their intent is to have a medically induced abortion. That's not always the case. Frequently, families just want more information to be prepared. Either way, be very caring and non-judgmental in your nursing care of these patients. Listed on the chart in your text is a simple blood test called a cell-free fetal DNA you may have heard of. Sometimes it's also called the FISH test. This is an amazing new test, gotta love technology, that can actually, through the mother's blood, determine some genetic and chromosomal issues of the fetus. And this can be done early in the first trimester at approximately 10 weeks as well. This is obviously much less invasive, has much less potential risk for both mom and baby. It has the potential in the future to possibly replace chorionic villi sampling and amniocentesis, or at least help rule out whether these tests would need to be done or not, so we wouldn't have to do quite as many of them. Other tests for you to review on that prenatal test chart on page 357 would be the fetal nuchal translucency, very commonly done via an ultrasound between 10 and 14 weeks, and triple and squad training tests, which are simply blood tests that, again, are going to be looking for Down syndrome or neural tube defects. As your fetus becomes older and you are starting to screen the fetus itself for how well oxygenated your baby is, the non-stress test becomes the most commonly done test on a fetus after 24 weeks. As you can see in the picture, this involves the fetal heart rate monitoring, which you are all now very familiar with, right? Over here you have your fetal heart rate tracing. What is the first thing we look at to read a tracing? We're looking at a baseline. Next, we're looking at variability, which in this tracing looks moderate. And then we're looking for periodic changes. I see accelerations. I see no decelerations. So when I'm looking at this fetal monitor strip, if I had 20 minutes of a tracing like this, I could say I had a reactive NST. My baby is reacting to the uterine environment, showing a well-oxygenated brain. If I have a reactive NST, I have a 99% probability that there will be no bad outcomes within the next 72 hours. Some physicians' offices will do this test on every antepartum woman at some point after 24 weeks. Others will wait and only use this test for patients who have additional risk factors. This is probably, again, the most common fetal surveillance evaluation that we're going to see in pregnancy. A contraction stress test is not nearly as common. It's very rarely used. However, you need to be familiar with it because it gives us very valuable information when scenarios come up that we need to use it. It involves inducing a contraction, monitoring the baby throughout the contraction to see how well our baby is tolerating contractions. If I had a mother who had a non-reactive NST and I knew she was going to be induced for labor, I might want to do a contraction stress test to evaluate how well my fetus could tolerate those contractions. Remember in our fetal heart rate monitoring lecture how perfusion to the fetus decreases as the contraction intensifies. A technically well done contraction stress test is going to be attaching to the monitor, mom to a fetal heart rate monitor, inducing contractions, and getting to the point where you can see 3 contractions in a 10-minute period. If I continue to have no decelerations and moderate fetal variability, I have a negative contraction stress test. There are no signs of distress. It is negative for problems. If I have a positive contraction stress test, it is positive for decelerations or decreased variability. Don't let the two terms confuse you. A negative contraction stress test is a good thing. A positive contraction stress test means we need to seriously consider whether this baby will tolerate labor or not. A biophysical profile, more commonly called a BPP, is done with both ultrasound and fetal heart rate monitoring. This is, again, probably the second most common test after the NST that you're going to see to evaluate a fetus during the second and third trimesters. Biophysical profiles are usually done at 24 weeks and greater. Ideally, some facilities will say 28 weeks. They consist of 5 different categories. The ultrasound tech will look for fetal breathing movements. Remember, babies don't actually breathe. Your fetus isn't intaking air. What your fetus is doing is moving their diaphragm up and down to simulate that breathing movement. A baby that has the oxygen reserves to practice breathing is a baby that has oxygen to spare. So we look for fetal breathing movements. We look for gross body movements, meaning I'm looking for arms and legs to move. I want to see that baby moving and kicking. Again, if the baby has the oxygen to move, I can be pretty sure my baby's doing well. Fetal tone means I am looking at the tone of the fetus. Are my arms and legs tight in fetal position? Are they limp and floppy and floating? If the baby has relaxed or loose tone, that is not a good sign. My baby does not have the energy to keep that fetal tone that they should have. A reactive fetal heart rate, also usually some facilities will simply say a non-stress test. Non-stress test is reactive. I know that my heart rate is getting the oxygen that it needs. Last but not least, I am taking a quick estimation via ultrasound of how much amniotic fluid there is. This isn't a measurement of amniotic fluid. It's just a quick look to see if it's there or not. Each of these categories receives either 2 or 0. There is no 1. So they should add up to a total score of 10. Many facilities will take out the non-stress test. They will send the patient to the ultrasound department and simply do a BPP with 4 categories, which means your total will be 8. If you have a total of an 8 out of a 10 or a 6 out of an 8, I am concerned, but I'm not too concerned. I'll want to reevaluate my mom and baby and see how they're doing soon. A score of 6 or below from 10 or 4 or below from 8 means that I need to do some more invasive and aggressive monitoring that may involve delivery in the near future, or it may involve simply admitting your patient to do further tests such as a Doppler ultrasound and continuous fetal monitoring. Comprehensive assessment of fetal well-being involves monitoring of fetal growth, placental function, as well as central venous pressure and cardiac function of the fetus. A Doppler flow study involves a highly trained ultrasound technician using a very expensive, highly technological ultrasound machine. Using this material, they can measure the velocity of blood flow via ultrasound, and they're looking at the blood flow within the uterine artery, the umbilical artery, and the middle cerebral artery. If they have rising diastolic ratios, they know they have decreased blood flow to the placenta. Obviously, that can be a problem. In pregnancies complicated by hypertension or fetal growth restriction, that diastolic blood flow can be absent, or it might even be reversed. If I have a patient who has a non-reactive NST, I will usually follow that up with a BPP. My biophysical profile might come back with a 4 out of an 8 or lower, or maybe a 6 out of a 10 if I include the non-stress test in that BPP evaluation. If I have 4 studies, this would be a great test for me to follow those up with so I can get more accurate and better information to help me plan individualized patient care for this pregnancy. If I have this information, that's going to help the provider decide how far they can prolong the pregnancy compared with the risk that the baby's not tolerating the intrauterine environment and may need to be delivered early. Frequently, the issue in complicated high-risk pregnancies is how long can we keep her pregnant versus the risk of preterm birth. Risk versus benefit is the basis of most decisions made in this scenario. These highly technical tools can give us great information so we can make better decisions about that.